Is this thing on? Right. As the famous philosopher Timberland once said, it's been a long time. We shouldn't have left you with a dope beat to step to. We can only apologise for the delay since our last podcast release was over a year ago, but we've been busy working on something exciting and groundbreaking for the next step in the evolution of Author Hub and recording lots of new content that we'll be able to share with you very soon. But this Author Hub C1 Do On podcast is my baby. This next podcast is one we actually recorded a couple of years ago, and as you'll soon see, it's a difficult one for me because our next guest is Getgood, one of the biggest names in knee surgery. And since then, he's soared even higher, and I'd put him in my top 5 knee surgeons in the world. If you're interested, then leave a comment below. I'll tell you on my Instagram who the others are. The reason it's difficult for me is because he who cannot be named is a couple of years ahead, and everything I wanted to achieve, he got there before me and did it first. And it burned, as you'll soon find out. And then, when as a Liverpool fan, I found out that he was a Man United fan, everything was 100 times worse. And then we did the podcast, and he came across as funny, likeable, intelligent, and thoroughly charming. And then I visited him at his new place in Qatar, at Aspetar, where he's the chief of surgery, and we hung out. Our families hung out, and we met his wonderful wife and boys. We had lunch together and went wake surfing on his boat. And yes, he did try to drown me, but I don't think it was intentional. And my respect and admiration for the man with a funny accent went up even further. I'll be seeing him at Isokos in Munich in June, where he is the program chair, and we might even share a Coke Zero. If you're watching this, you'll see we recorded this a few years ago. As you'll see, I'm about twice the size I am right now. All this to basically say we've been really crap and we haven't edited or released the podcast for a huge number of operational reasons that I won't bore you with. But I honestly think this is our best one yet, and so much fun. So check it out. But first, a word from our sponsors. Before we get started on our Getgood, there's a special reason that Pete and I are here in our green screen. You probably can tell it's a green screen from the background.
We're not really on a Star Destroyer after all. By the way, before we get into this, what's going on here? You've still got the label on this. You can still see the fold marks. Can we remove this, please?
No, this is hacky. I want people to know this is new. This is a special occasion.
Whoa! What happened there? Something's changed about you. Something's not right. Is this galloping consumption? What's going on?
It's the pocket square. That's new.
You've gone from like Mr. Potato Head to something really quite different. What's happened?
Yeah, you know, they say the camera adds 10 pounds. We had 5 cameras before, and now we're down to 1. I think that's the difference. You don't get a body like this overnight.
No, okay.
That's what I would say.
Okay.
I made a concerted effort, Pete. You know, we are, once a man gets to a certain age, one has to take...
This is the new healthy Cash. This is wonderful to see. It's wonderful. Are we going down the gym as well as just hitting the fasting?
I'm working with a personal trainer, heavy weights, 3 times a week.
Wow.
150 grams of protein.
Wow.
I know, I'm on it.
Okay, smashing.
It's all about the gains.
Okay, don't give yourself a kidney stone or anything like that.
Gains with a Z. So, Pete, why are we here?
Why are we here? Podcasts don't cost nothing. We all know that, and I think we're all familiar now with podcasts funding themselves with sponsors. So this is the sponsorship bit where we say who's sponsoring us and why we love them so much. And who is that?
And our sponsor
today is Lavender Medical. What do we know about Lavender Medical? Cheat sheet. That's a blatant cheat sheet. Anyway,
I know this off the top of my head, but Lavender Medical are a UK family-owned business.
Yes.
Just north of London. In Letchworth Garden City.
Okay, so that's near Stevenage, right?
Yes, that way, yeah.
Near Biggleswade, not so very far from the Cardington hangars, where they used to build airships. There's these massive hangars. They're really also these massive front doors that look like 5 stories high. They're still there. I think it's a film studio now, but they're just looking at those. It's an awesome building.
So Lavender Medical have recently opened up their own cadaveric lab.
Yep.
Called the Hive Surgical Centre.
Hive. What does the hive stand? Is the I for insect? There's something about being close up to insects.
Yeah.
I just think of that. Imagine there's a massive bee right next to you. It would be pretty.
There's going to be a shitload of them behind us right now. Fabio, can you put the bees up for us? Holy. So Hive stands for the Hub for Innovation, Validation and Education. And there they've got 5 stations, including arthroscopic stacks to host cadaveric medical education.
Okay, right. So it's Medical Education Centre.
Yeah.
Yeah.
So just a bit more about Lavender, because we are very grateful to Lavender as being our inaugural sponsors.
Yeah.
They are a UK distributor of orthopaedic implants for over 15 years. Originally, they focused on
foot, ankle stuff.
And hand and wrist.
Hand and wrist. They're still doing that, right?
Extremities.
Loads of like gnarly foot screws. If you want your toe fused or your ankle sorted out or your first MTPJ replaced, that's your man.
And they are still recognised as a true one-stop shop for all foot and ankle solutions. Over the past 6 months, they've announced partnerships with 2 innovative sports medicine suppliers.
Yeah.
They're moving more into sports medicine. They've launched the biotech sports medicine range, and they're bringing an Indian-based and another family-owned and run company into the UK as their exclusive distributors.
What's this Xeros, or is it Kiros? It's spelled Xeros, Z-X-I-R-O-S, but you're supposed to pronounce it Kiros?
Yeah,
Is that right?
Kiros. It's pronounced Kiros. So
It's a
basically,
Greek thing.
Kiros was formerly Neoligaments, and they do synthetic ligaments.
Okay.
And they've become really popular for things like MCL reconstruction. They're being involved in various ligaments around the knee. And so that's something that people should really be interested in.
All right. Lavender Medical.
Lavender
Thank you for sponsoring our podcast.
And I'd like to say thank you to Steve Fee. Steve's been, I've known Steve actually. He was,
He's a lavender guy, right?
he's a lavender guy. So Steve was our Synthes trauma rep. And he's bailed me out of quite a few tricky nailing situations when I was a junior registrar.
Oh, nice. Okay. Yeah.
Yeah,
So there's when
Yeah.
someone does that for you, then you don't forget it, do you?
Honestly, it is underestimated that if you have a rep who's bailed you out early in your career, there's a bond there for life.
There is. It's true. It's true. Yeah.
Especially if it's on a weekend, you know.
Yeah.
In
At a time where you were genuinely desperate, and they came and
the misery of Paddington.
they rode in,
Yeah.
sorted it out.
Yeah.
Yeah.
But I think,
For
so Steve has been great. So listen, I'm very grateful to Steve for all his support and sponsoring the podcast. And if you see Lavender Medical at a conference or congress, please go over to them. Please say hi. Do go and visit the Hive.
I want to come to the Hive.
Go to the Hive and
See your insects.
say hi to them and say that Author Hub sent you.
Great.
Happy?
Roll on. I'll get good.
I'll get good. On with the show.
Looking okay? Yeah. Hello everyone, welcome to the latest edition of the Author Hub C1 Doing podcast with me, Kash and him, Pete Bates. Pete, it's been a minute since we've had a guest in the studio, isn't it?
I know it's been a long time. Yeah, we've it's all been online so far, hasn't it?
Yeah, I've pretty much forgotten what to do because our last 3 recordings have all been online, not had anyone here. And then all of a sudden, and then Al...
We've got a dude looking at us.
I know. Well, not only that, I'm still feeling intimidated because he sent us his CV, which was about...
8 miles long.
It was a very professional approach. It's like, not compared to what we normally do, just Google someone in the morning and have a look at their Twitter. And it was 59 pages, and it was all killer, no filler. There was no kind of best presentation at E4 on there. Yeah.
That's because I never got a best presentation at E4.
Yeah. That'll be why.
There's no TikTok though, is there?
There's no there. But literally, this CV just landed in my inbox, and he just flopped it on the table. And I was just standing there, intimidated.
Nuts and all.
I was intimidated in the corner. I go, oh, go over here. Pete, what are we talking about today?
We're talking about
L.
Just on L.
Is he Arabic? El Getgood.
I was watching Stranger Things last night.
Yeah.
It is. Today we've got Al Getgood.
Well done.
Al Getgood is a sports knee surgeon in Canada, and you're going to tell us all about him. What you'll notice is that whenever we have a sports surgeon come in, Kash gets a bit dressed up. He puts his suit on. He puts his little pocket thing, his lapel pocket, and he but because normally it's just like a bombed out sweatshirt for most people. But today you're honoured by his. He's
Truly honoured.
frocked up.
Truly honoured.
He's quite warm in here. You must be sweaty. He's got like 4 layers on there.
I'm feeling a little bit hot here. No, genuinely. So when we started, we had a wish list of the guests that we wanted. Do you remember we sent that list?
Yeah.
And you were in my top 5.
Good to know.
I won't tell you where you were in the top 5, but you're on the wish list from the very beginning. So our guest today is Alan Martin John Getgood,
Oh boy.
known to all as Al Getgood, one word, or Wee Al to his friends, and he's the thinking man's Mo Bandari. He's a big lad, isn't he?
He is a big lad, yeah. I haven't seen him standing up yet.
Okay. You're just going by the size of the CV. So, big shoes. So Al Getgood is an orthopedic surgeon and clinician scientist specialising in complex knee reconstruction at the Fowler Kennedy Sport Medicine Clinic, London, Ontario, where he's also the Sports Medicine Fellowship Director and Associate Professor at the University of Western Ontario. If ever I've seen someone who should be a full professor, and will be, no doubt, but should be already, it's this guy. I don't know what they're playing at in Western Ontario. So he completed his primary medical degree at the University of Edinburgh in Scotland and basic surgical training in Cambridge, followed by orthopaedic residency in Cambridge and a research doctorate, what we refer to as an MD over here, at the University of Cambridge. His fellowship training included time in London, Ontario, Banff in Alberta and Coventry, UK, with friends of Author Hub, Tim Spalding and Pete Thompson, before going to Canada for good. Why you'd ever want to leave Coventry for Canada, I don't know.
What was the thinking?
It was a tough one.
Well, we should find out. He's been successful in securing over $9 million in peer-reviewed and industry-funded grants to build his preclinical and clinical research program. It focuses on the complex ligament reconstruction and joint preservation. He's a board member of the American Orthopedic Society of Sports Medicine and the program chair for ISACOS 2025. Where will that be held?
Not sure yet. It's going to be in Europe, probably either Brussels or Munich.
Okay.
Time will tell.
Time will tell.
The pissing boy
Yeah, in Brussels.
in Bruges. Yeah.
Yeah. For people who don't know what he's referring to the statue of a young boy fountain where he's peeing.
That's right.
Rather than Pete's being crude.
But I'm not sure what the story was. There's a story. Why is what's that? We need to find that out.
It's on every T-shirt and keyring
Exactly,
coming out
yeah,
of Brussels.
Yeah.
Particular achievements for Al Getgood include being awarded the J. Edward Sampson Research Award from the Canadian Orthopaedic Foundation, which is the premier research award in Canadian orthopedics, the American Orthopaedic Society of Sports Medicine O'Donoghue Sports Injury Award, and the Jan Gilquist Award and the Albert Triat Young Investigator Award, both from ISACOS for the Stability Trial. I'll do that bit again.
Yeah.
For the Stability Trial, which is an international multi-center randomized controlled trial looking at reducing the risk of ACL graft failure in young active individuals. It's quite possibly the most valuable piece of research in medical history. Just ahead of the discovery of penicillin, which was a total fluke. It was not peer-reviewed. Al has authored over 140 peer-reviewed articles, many book chapters, and has given over 200 national and international conference presentations, lectures and demonstrations, including many live surgeries. I mean, there's quite a few live surgeries there, and they're not minor operations either.
We've had some fun ones.
Have you?
Yeah.
I mean, it's hard enough. Even cadaveric surgery is never that fun demonstrating that, let alone live surgery. He's a member of the AOSSM Board of Directors and sits on the Knee Preservation Committee of ISACOS. He's a member of the prestigious DICA Society, which Andy Williams is in as well, and the ACL Study Group, which will be the program chair next year. I'm desperate to join the ACL Study Group. So
noted.
Desperate to be invited.
Yeah.
Please invite me. Please invite me.
I mean, it's on merit, but if you can help a brother out.
Program chair, far in the abstract, you never know.
We'll find something. And a founding member of the International Meniscus Reconstruction Forum. Al is also a visiting surgeon at the International Knee and Joint Clinic in Abu Dhabi, UAE, and the Aspetar Sports Medicine Clinic in Doha. And he's the proud owner of a Hungarian Vizsla.
Vizsla?
Yeah.
Oh.
Best dog ever.
What do they look like?
They look like a Hungarian pointer. Skinny brown dog that runs a lot.
It runs.
Fantastic.
Okay. They run a lot.
Yeah.
Okay.
And I'm going to finish with this personal testimonial that I've received. It says, he is a rare breed. He's not only academically and clinically very able, but he's also extremely kind, personable, and generous with both his time and knowledge.
Oh, who came
There you go.
Yeah.
Who came up with that one?
I can't tell you, but frankly, it makes me sick. Al, welcome to Author Hub Towers.
Welcome.
Thanks, guys.
Because you've gone from the UK over to Canada, you've got one of these like up accents. Just I mean that in a nice way. Where are you? Are you Scottish? Because you trained in Edinburgh. Are you English? Are you Scottish? What?
I think he's Scottish. I'm pretty sure he's Scottish.
You've gone down as Scot.
Really?
Yeah, I've always thought you were Scottish, but I can never place your accent on the podium.
Northern Ireland.
Northern Ireland?
No way. Right. Okay.
Northern Ireland.
So Belfast, well, just outside Belfast, Lisburn, Northern Ireland.
Four.
Okay.
But yeah, I've lived in so many different places I don't really know where I'm from. Yeah.
Can you say four?
Four.
Okay, not four.
I can say four as well.
Yeah. Okay.
A couple of beers and it all changes.
It all changes, then it comes out.
Right, Northern Ireland. Mm-hmm. And so, what took you from there to Edinburgh? Why'd you go to Edinburgh straight?
It was pretty common for us to leave Northern Ireland to go across the water for higher education, and that was a pretty common thread. Scotland was an easy manner to travel. It was only a quick boat across the Irish Sea, and so you didn't have to worry about spending a lot of money on flights. So it was very easy to go to Scotland from Northern Ireland, and Edinburgh was just a great place to go and then be at medical school. So it was a pretty easy transition.
How are Northern Irish people received in Scotland? Because like English people are like a pretty foul taste, frankly, in in the mouths of Scottish people, but Northern Irish people better received over there.
I would say probably Northern Irish people are received pretty well anywhere. So we do okay. We do okay. So I mean, it was a great place to live.
The Irish generally, as a whole, north and south, but northern in particular, raise no antibodies anywhere.
Yeah, that's right.
Whereas, I met Bertrand Sornicotte the other day. He was a "you English bastard," and that was his greeting. And so the Northern Irish are very popular people.
Yeah,
they're nice people.
Oh, we try.
What was it like? So you would have grown up during the Troubles, I guess.
Correct. Yeah.
Yeah. What was that like?
It was interesting. It was interesting. I mean, I was very lucky. I lived in a middle class background. Lived in the countryside. Really didn't have a lot of first-hand issues.
Yeah.
But of course, we would go into the cities. We had a big military presence all the time. So, seeing a 6-man military patrol walking down this, the center of your town was just normal.
Right.
Lisburn had the major army barracks, the Thiefel barracks. So we had a massive bomb there one day when I was at school, when I was at grammar school, and the whole dining hall window shook, and you could have heard a pin drop in the room. So there were times it was pretty scary. Other times it was just business as usual. It wasn't really a big issue, and we just got so used to it. I think when I would bring friends home from Scotland at university, they were totally freaked out, seeing a Saracen tank drive down the road past us. Wasn't the normal sort of day-to-day activities. But these guys, the guys with the military guys were friendly to us for sure. It wasn't a big deal.
When you go back now, how often do you go back?
Pretty rare. I don't have any family back in Northern Ireland now,
Okay.
so it's really just school friends and a couple of university mates. So it's been a long time since I have been back, and it's changed massively. It's fantastic. When I lived there, it wasn't a very diverse culture.
Yeah.
I think that's really changed, and there's been a ton more investment. A lot more. Just the culture is completely transformed. A lot of the places that I would not have gone to, because it was maybe a little bit too dangerous, are now tourist attractions. And it's really, really interesting.
Yeah.
So it's a great place to visit.
We had the BOA there a couple of years ago.
We did,
And it was, you were there. We had dinner.
lovely. It was lovely,
It was
yeah.
lively, wasn't it?
It was. You then went to Cambridge. Why Cambridge?
I wanted to move down south. I was actually dating a girl at the time in London, so there was definitely a move to
a reason to come.
Yeah, and
Is this your wife now?
no, it's not.
Okay,
Actually,
let's not.
I actually met my wife in Cambridge, so actually that's rescued that one maybe. But I was applying for SHO jobs, so I was trying to get a job in accident emergency, and then wanted to get onto a basic surgical training program, and so I got an opportunity in Cambridge and jumped at it, stayed there, did my SHO training there, and got onto the orthopedic program there. So it was kind of seamless.
Tell us about Cambridge.
Great place.
It's not dissimilar to Edinburgh in some ways, isn't it? A very beautiful town, not massive. You can walk around it.
Yeah.
It's absolutely beautiful, stuffed with tourists.
Yeah. It's a phenomenal place. But I guess like a lot of times, I would say I did the same in Edinburgh in many ways. Is that when you live somewhere, you don't necessarily take in all of the history and a lot of the time, a lot of the tourist attractions. And we only started doing that just before we left Cambridge, and did one of these walking tours and learned so much more about the city and the architecture. It's
that's what that thing is.
It's fascinating. But I think if you haven't been there as an undergraduate, then sometimes it can be a little bit more difficult to get into the college culture.
Yeah.
For me, it was great because I was able to do my postgraduate degree there, so I did my MD there. So at least then I got an experience of the college.
Which college was that?
Modelling.
Very nice.
But it was that was an interesting experience. Going to the modelling, for dinner and having to wear the robes and everything.
Yeah, for dinner.
I was in my late 20s, early 30s. And it was just it was kind of cool, but whatever.
And were you sporty? Were you like a rugby guy, football guy?
I played rugby. So I played rugby right through school and then in Edinburgh as well. So I played in the first 15 for a number of years, but I was always dogged with injury. It was kind of crap. So
Second row?
I was number 8 actually.
Okay.
Yeah.
That was my next guess.
Yeah. So I had a great time. Toured Australia with the university and had an absolute blast there. 30 guys on a rugby tour and on the east coast of Australia. It's not bad.
Say no more.
No, what goes on tour stays on tour. Yeah. But we had a lot of fun. But it was Edinburgh was a great place to be.
SPR training was in Cambridge.
Yep.
And then fellowship was in Canada.
Correct. Yeah.
And what took you there?
I think I looked around what was where most soft tissue knee surgeons were what fellowships they were doing from the UK. The majority were going to Australia, New Zealand. Great fellowships, great opportunities, but I would say that a lot of people were coming back with very similar training, very similar skill sets. And I think at an early stage, I thought I wanted to do something slightly different, because my plan always was to come back to the UK and set up practice in the UK. But I wanted to try and offer something different. You want to try and stand out at the end of the day. And I thought going to North America would be the way to do that. The US was a little bit of a tough nut to crack in that I didn't have US MLEs.
Yeah.
And Canada would accept my training. So, and I wanted two different things out of my fellowship. I wanted to have sort of an academic side of things and do a lot of work, but also, my wife and I wanted to have some fun.
Yeah.
So we did 6 months in London, where I currently am. The plan there was 6 months and never go back, really. But we had a fabulous 6 months, and we learned an awful lot, enjoyed the time there. And then we had 6 months in Banff during winter, and
wow.
I love skiing.
Yeah.
I'd never had an opportunity to do a ski season, and this was a great opportunity. And for 6 months, we skied hard and worked incredibly hard. I did more ACL reconstructions in 6 months than I think I could ever dream of. And
who were your fellowships with in Ontario and Banff?
So in Ontario it was in Fowler Kennedy. So Bob Litchfield, Bob Giffen were the guys I was working with at the time. And then in Banff was Mark Hurd, and Mark's just one of these. He is a real unique person, very, very talented surgeon, but just a real mountain guy. He's one of my favorite people. I've spent so much time in the backcountry. It was a very interesting fellowship in that we'd spend Monday in the OR, and then the next day we'd be out ski touring, and we would do 6 hours in the backcountry, talking about what we did the day before, talking about life. Just a very different feel to the fellowship. It wasn't all about work, and it extended outside of that. And then we'd finished. We'd get some turns in the powder. It was amazing. He would always bring his dog with us. Really cool dog actually. There's this dog called Jackson, and he would come skiing with us. So we'd be hiking up the hill, and Jackson would be in our trails, and then on the way down he would just be in the powder, bouncing down through with his little ears poking out above the powder. And actually my son was my second son, Freddie, his middle name is Jackson after the dog.
After the dog.
But
like Indiana.
Mark was very special. And then after the ski tour, we would come back to the hospital, do a quick word round, and every patient we'd see, the first few conversations would be about the turns that we had in the hills.
It's really hard to match that in London.
Yeah, for sure. So it was good experience.
So from Banff to Coventry.
Absolutely.
And I know Kash doesn't find this difficult to believe, but some of our listeners, what pulls you into sports, into sports knee? What was it? What was the draw?
I guess from being involved in rugby at an early stage, I always wanted to be involved with sports. And then my first house job actually was in Livingston, just outside Edinburgh, and I worked with a guy called Graham Lawson. And Graham was at the time one of the doctors for the Scottish Rugby Union, so he would run sort of Monday, or I can't remember what day it was, but the lunchtime sports injury clinics, and I would hang out with them over lunch, and it was just great, just seeing some of these athletes and working with the players, and I thought, this is something I really like to get into. And it just grew from there. And when I was in Cambridge, I looked after the Cambridge rugby team, and it was good. I think the motivation of athletes to get back to the sport is something I really enjoy. It's great looking after maybe older people, and you want to get them back to the normal activities of daily living. But I think with athletes, they just provide a slightly different challenge. And they're a very challenging population. And then the knee, I did knee and shoulder initially. I always thought I was going to be a knee and shoulder surgeon, but I dropped shoulder after about 2 years of practice. I realized I was probably a better knee surgeon.
And also, the shoulder patients generally are quite mental. They're the ones wearing sunglasses in the waiting room, aren't they?
It's the limp hand. It's when you try and shake their hand, and it's like, that was a great outcome.
But listen to this, right?
Yeah.
Well done. That's a good. But how did you end up in Coventry? Tell us about your fellowship there. How long were you there?
I was there for 6 months
with Tim and Pete.
With Tim and Pete, and so that was planned. That was planned all along, and there's an awful lot of luck, I guess, in the way I've gone through my training. But just everything worked out very well in terms of the year, and Canada just gave me an awful lot of experience in terms of just good operative volume. And then going to Coventry, Tim, I think, likes to think of it as finishing school, and it really truly is, because the practice is very complex. because I had a decent amount of cases, behind me, I could actually get on and do some work. And so, you had your own operating list. Tim was at that time, again, was building his practice in meniscus transplantation. So we were doing probably a meniscus allograft every, probably 2 a week. It was just insane numbers.
Huge numbers.
And that volume just grew and grew and grew. And then I stayed on for another 6 months as a locum consultant there at the university. And that was fabulous because that was the transition between leaving and going to Canada. So I wasn't trying to build anything. I wasn't trying to, grow my practice. I just needed to work for 6 months. And Tim just fed me an awful lot of big cases. So I was straight off the bat, I was doing very complex surgery, knowing that Tim and Pete were there to help me out if I had any problems. You had their full backing. Again, mentorship. Just, you couldn't ask for anything greater. Yeah. And so, and then when I moved to Canada, I was hitting the ground, hitting the ground running. It was a really very, very seamless transition.
And what year were you in Coventry?
That was 2011, 2012.
Yeah, so you would be in the fellows. So that was the time that I'm still quite sore about this. So I wanted to do that fellowship with Tim Spalding, and we'd presented at Basque.
A better man got the job. Is that what you're saying?
You need a bigger CV, mate.
No, I was applying for like 2 years after that, but I wanted to apply at that time. And basically, we were at Basque and we'd presented together. And then I went up to Tim afterwards and I said, I'd really like to apply for your fellowship, and he refused to even discuss it with me. And I never even got an application form.
Yeah, he discussed it with me.
Did it?
So, no, I'm joking.
It still hurts. No, and the thing, because I ended up winning best presentation in the same section he was in, so I think he was a bit sore about that. But the irony now is, 10 years on.
That's what it was.
Yeah,
of course it was.
Of course it was.
Yeah, it had nothing to do with caliber.
No, but 10 years on now, we're partners and colleagues, at Cleveland Clinic London. Yeah. So, I always play the long game. So you were set up, you'd had great training, you had a really strong CV even at that stage, and you were basically a local consultant here.
Yep.
So you're going to end up as a consultant here in the UK. So then all of a sudden, how did you end up in Canada?
When I was in London, just at finishing my fellowship in London, they
Ontario.
asked me, so they asked, I always said in London, Ontario, London, England. They asked me whether or not I'd be interested in coming back, and that was totally out of the blue. Didn't expect that coming at all. And in many ways, it was an offer that I couldn't refuse. Now, when I did move back to the UK and spend some time in Coventry was a great place, and I had an opportunity to stay on there. And it was difficult. It was a difficult decision. There were pros and cons of each. But I think what really swung it was, Canada's a very unique place to work in many ways, and there are great things about it. There are some negatives about it. But what was very obvious is that as soon as you set up shop, you could build a pretty complex knee practice very quickly. And also, there are multiple reasons, but you have opportunities for doing research, opportunities for, probably a better work-life balance in many ways.
Sure.
You've got one practice that you have to focus on. You don't have a private practice as well. My partners at fellowship, the guys I worked for at the time. It's maybe a bit of a flippant comment, but I think it's pretty important. They were all in their first wives. That's huge, right? They were all happily married, with children, and we looked at that and thought, well, that's important, right? So you could see that there were some massive advantages from a family point of view. Our operating days finish at 3:30, and so I can be home in the evening and spending time with the family. So many different reasons, but I think those are the main things that really swung it.
It's a very good point. Pete, what number wife are you on?
Still number one.
That's a clear lack of ambition there.
and not wanting to focus on negatives. What are the downsides of working in Canada?
I guess access to infrastructure. So for operating times, probably the biggest issue is getting your patients into the operating room in a timely manner. We have massive issues with that right now. So I have a finite amount of operating time available. So I've got a huge waiting list. Yeah. But it's very it's very difficult to get patients in, particularly who are needing acute care. So you spend a lot of time rejuggling your lists. I'm the main sort of person that does multi-ligament knee and reconstruction. That all has to be fitted into my elective time. There's, it varies from hospital to hospital as to how they're set up in terms of their trauma provision. So, I think the major advantage for a patient is that you're not going to be made bankrupt by being sick. But at the same time, if you don't have a really acute, urgent problem, you can be waiting for a very long time for access to care.
Yeah.
And as a physician, that's pretty challenging. So then you have to manage your resources, and you have to make now. You could also, the flip side of that is that we have great autonomy. I can decide what my list will be if I do have an acute problem that has to be sorted out.
Yeah.
I don't have a manager that says no, you can't do that. So there's a lot of shuffling around, but I'd say probably the access to operating room is probably the biggest challenge.
I mean, it is here as well, but so for the multi-legs, when I do them, I have to put them on my trauma list.
Mm-hmm.
But luckily, I have a trauma list I have access to.
Yeah.
But you are right. Even the waiting list is a growing issue here now, obviously post COVID.
Yeah.
And so that's certainly an issue. But having now seen the Canada practice, the UK practice, and US practice, I mean, you're intimately familiar with all of those.
Yep.
Is Canada in the middle somewhere?
Yeah, I mean, I think it's just very, very hard to put it into one specific area, because it excels in some areas, and then in other areas it's pretty poor. I mean, I'd say in London, our wait time for a joint replacement right now is about 2.5 years. I mean, that's crazy. That's back what the UK was like 30, 40 years ago. So, I think that's inappropriate. And the real downside is that patients don't have choice, right? It's not like they say, well, okay, I don't want to wait for 2.5 years, so I'll go to the private sector. There really is no private sector.
Right. Other than going to the US.
Other than going to the US. And, and that can bring its own issues, right?
Yeah.
Can be very, very expensive. And depending where you go, the quality of care may not be quite as good. And I say that very carefully, because I think the care down there can be, excellent.
But it's variable.
It's variable, but I think everywhere is variable. There's variability everywhere, no matter what you do.
And follow-up's difficult when it's
right.
hundreds of miles away.
Right.
Yeah.
Where is London and Ontario on the map? Forgive my ignorance.
So it's right between the Great Lakes. So if you imagine Toronto and Detroit, we're right in the middle of the two.
It's the east side.
So it's on the east coast.
Right.
Well, it's not east coast, but it's right. If you imagine, so you got Lake Ontario, Erie, and Huron. It's right in the middle.
Does it snow a lot there?
It does. We're actually on a snow belt because of the lake effect snow.
Right.
So we get a lot of snow. So
it's cold a lot of the time.
It's cold, yeah, but that's very manageable cold. I mean, it's not a big deal. I think you just you wear the appropriate clothing. It's absolutely fine.
Yeah.
And often when it's really, really cold, it's beautiful. It can be often blue sky day, minus 30, and it's gorgeous. So
do you get bears? Got bears rocking around?
They're not quite down. They're a little bit too south, but go a little bit northern Ontario for sure. You get black bears, yeah.
Yeah. Which are the bears to get scared of?
Grizzlies, mate.
Grizzlies.
We don't have any grizzlies on the Ontario, no grizzlies.
Okay, so let's just have some scenarios. You confronted with a black bear, not a grizzly, a black bear in front of you. You're out in the woods, let's say, and it's just you and the black bear. What are you supposed to do? What's the sort of like standard mantra of what you're supposed to do? Black bears.
I love that. You're asking the guy from Northern Ireland who's lived in Canada for 10 years what he would do about facing a bear. What I've been told, Pete.
Yeah.
It's kind of interesting with I think with black bears, you're meant to be really loud. Okay, so essentially, well, like the whole time you're out hiking, you would just make lots and lots of noise. It was actually Mark Hurd told me this when I go for a jog when I was living out west. He would just say, I just keep making lots and lots of noise and make a whoop every so often. So I'd be running along making whoop, whoop, right? I still to this day think he was taking the piss, right? And he's probably sitting at home having a good old laugh over a beer. Getgood's out whooping his way around Banff.
Everyone else again is that nutter.
So I mean, that was the token joke maybe, but no, you make a bit of noise, right? Grizzlies on the other hand, no way, right? If ultimately you just don't want to meet a grizzly. If you get between a grizzly and a cub, you're stuffed.
Yeah.
And then if you get really in trouble, I mean, obviously you have bear spray, hopefully. But if you don't have bear spray, you get down on the ground, you cover your back, and you hope, and you just
play dead.
Hope that it'll have a little.
Grizzlies are the ones where you're not supposed to move. Is that the one?
Yeah, you lie down and you just play dead.
All right. And what's the difference between? I'm showing my ignorance here. I don't know the difference between a black bear and a grizzly bear.
One's pretty grizzly.
Is one no? But how are they different colour?
So one's black.
Right.
There's a clue in the name. But
I got that bit. I've excluded the black bear. I'm trying to look at how to get the grizzly.
But I couldn't tell honestly. I think the grizzly's got a slightly longer nose. I think I've never actually seen one up close and personal in the wild. So actually, that's the lie. I saw one in Vale once. I was at a course in Vale, and we were out hiking with my fellow, a guy called Bart van der Links from Belgium, and we were hiking down the mountain. We see this thing off in the distance. I'm like, that looks like a grizzly cub. And he goes, oh, let's go and take a look. I was like, nope, nope, we're going that way.
So you're not supposed to punch the grizzly on the nose. Is that a whale you're supposed to punch on the nose?
That might be
shark.
It's a shark. It's a
Okay.
great
Yeah,
white
so
shark.
you try and fight the black bear,
Yeah.
don't fight the grizzly.
Okay.
There's only one winner. There's only one winner, mate.
It's French, right? Ontario is French.
There's parts of it, the very far east side of Ontario, and Quebec is definitely, there's a French
Right.
side to it, yeah.
Okay.
But the rest of it is not French now.
Okay. Do you, is French? Do you get a lot of patients coming through who's French their only language?
No. Well, yeah, I mean, we have some French Canadians for sure, and there's a lot of people who are bilingual.
Yeah.
I am not, so don't ask me to start speaking in French.
Yeah.
It would be painful. Quebec is has a massive influence on the whole country as a whole.
Yeah.
It's kind of
Okay.
interesting.
Yeah.
All the signs are in French.
Everything's, so if you get a cereal box, one side's English, the other side's French. So there's any government documentation, there's always a French option, there's the English option.
Yeah.
Go to Quebec, no, it's just all French. So, but but that's great as well. When you go to Quebec, I guess that's our as close to Europe as we can get, and we enjoy that.
And again, it's a totally unfair question to ask you, but how are Quebecians received in France? Do the French is there like a natural sort of fraternity between the two countries, or do they get on, not get on?
I think probably they get on pretty well. I mean, I think it would probably. I'm not entirely sure. You'd probably be better off asking.
I know.
Yeah, we don't want to start.
It was not.
Yeah.
He's
He's happy to talk about Northern Ireland, but let's not talk about Quebec. All right.
I can tell you about mountain biking in Quebec. That's about as far as it goes.
Okay, can I just dive down a rabbit hole quickly?
Sure.
In trauma, we often get there is a particular injury where you have someone who's extremely overweight, and they are literally just walking along. It's often a female, but not always. They're just walking along, they stumble, and their knee completely dislocates, and they end up
Ultra low velocity knee dislocation.
yeah.
Supra physiological.
And how do you manage those patients? Because they're the kind of the anti-athlete, the person that you were describing earlier, who's like well motivated and just wants to get better and wants to return to their, and they're often not of that mindset, are they? How do you manage those patients?
Thankfully, I don't have to see too many of them.
No,
I mean,
it's not super
it's
common.
not super common. I mean, certainly in the US, some of my colleagues down in the deep south would see an awful lot more. So the likes of Mark Miller, who's written about it extensively, that's a big part of their practice, which is kind of crazy. Most of the time, the challenge really isn't the first. And I'm sure you see this, in time zero, is just keeping the knee reduced. They often don't fit in a brace. So I think those are one of that types of patients where I do advocate for an X-fix.
Yeah.
I don't like external fixators generally for knee dislocations, but in those scenarios, then it's sometimes the only option that you have. I don't actually work in a level 1 trauma center, so the trauma guys will deal with most of those cases in terms of early management and then refer over. So if they were referred over with an external fixator on, I'll often just leave it on for about 6 weeks, take it off, do a manipulation under anesthetic, and then see what their laxity pattern is after that. The interesting thing with them is that you don't necessarily need to do a 3 ligament reconstruction if all 3 ligaments are out or if all 4 ligaments are out. They often really just need collateral ligaments, particularly patients, the obese patients often, whether or not they're in valgus or not, they often have a functional valgus just because of the size of their legs.
Yeah.
So if their medial side's out, which is often the case, they just need a medial post so that they can ambulate. So I'll often use a synthetic graft, for example, and just put a synthetic in just so that they can walk. Trying to keep them, using a biological tissue is challenging because they can't necessarily stay on crutches for a a period of time.
Yeah.
So they present with their own unique issues,
Yeah.
and you have to be able to sort of pivot around those and treat accordingly.
Right.
I mean, we see a fair few of those in London, actually.
Yeah.
They're really, as you're right, the functional valgus, their thighs are so large, it pushes the legs, and the calves push the legs into valgus. You can't often use a tourniquet on them.
No.
You're right, you can't reduce them in a brace or even a plaster. And there's a high incidence of vascular and neurological injuries with those, right?
Yeah.
And so you're right, I'm big on using synthetics for those because I just want a bit of rope.
Yep.
The strongest that you can get, and even still, it's under a lot of tension.
Yeah. Where are we with cartilage these days? Like the nirvana of orthopedics has always been to find a cartilage replacement of some sort. Where are we with cartilage at the moment?
I mean, it's a great question.
Osteochondral injury.
It's a great question, and certainly, like in my early stages, like at the end of my MD was in articular cartilage tissue engineering. So, my goal was to set up a cartilage restoration program in London. And I did to a certain degree. We did some early research around some animal studies and all sorts of stuff, and it was kind of cool. But the clinical translation for that has been relatively slow. And, I still am a proponent of cartilage restoration. I do a lot of osteochondral allograft, which is really good. I think that's probably the major thing that's really translated over the last decade, is more people doing osteochondral allografts with availability of tissue grafts. When I trained in the UK, we didn't have that. Now that is accessible to you guys.
It is, yeah, absolutely.
Yeah.
And that's probably a game changer for Europe, being able to access osteochondral allografts. Whereas in North America, we've had it for decades.
So, just for some of the listeners, that's basically taking a dead person's knee joint, taking a lump of cartilage and a little bit of bone with it.
Yeah.
A cylinder.
And then you plug that into your patient.
Correct. Yeah.
What happens to the cartilage? I mean, how long has this patient been dead for?
So it depends on the tissue bank. So actually, a lot of the original work came from Toronto. So there's a guy called Al Gross.
Yeah.
And Al's still working, and they still have the program there. So I access a lot of my tissue from the Toronto program. And it's viable cartilage, so the cells are still alive.
Okay,
probably, by the time of transplantation, you're probably around about 60-70% viability.
Right.
And ultimately, you're hoping that cartilage stays alive. The bone itself will get remodeled, through cream substitution. So the idea is that it's really the only procedure that you can resurface with true hyaline cartilage.
Yeah.
Whereas everything else, whether it's cell-based therapy or some sort of marrow stimulation, it's all fiber cartilage.
Yeah.
And so if it works, probably about 85%, like everything else in orthopedics, that's the sort of the good to excellent results. So it can be a very effective tool, but it's very expensive and it's not accessible to everybody. So that's probably the biggest challenge with it. In terms of all the cell-based therapies and orthobiologics, I mean that's taking off massively, and particularly in the States. Orthobiologics is the hot topic, whether that's autologous cells or allogeneic cells. That is. And there's a lot of regulatory pathways that need to be navigated through that, and we're seeing a big growth area there. From an evidence-based point of view, the evidence is definitely lacking behind.
Yeah.
And there's if we could talk for 2 hours on PRP. I mean, that's still a treatment that's still looking for a clear indication, and there's no question that it can help certain individuals in certain scenarios. The big question always is whether it's cost effective or not.
There's so many even flavors of PRP. There's like 20 different flavors.
But fundamentally, as you say, cartilage is hyaline cartilage that we weight bear on, has a very, very characteristic structure, doesn't it?
Yeah.
And so does bone, but bone is able to remodel itself quite quickly because it's got a blood supply going through it, whereas cartilage doesn't. And so recreating that unique structure in cartilage, which basically formed a bit like teeth or ears or eyes or whatever, it formed when you were an embryo, and then that's what you've got.
Yeah.
It's very difficult. Well, has anyone managed to reproduce that structure in anything other than an allograft? Like by putting culturing cells and putting them in your knee, or has anyone else
from a clinical translation into humans? I would say no. I mean, there's lots of good studies looking at the animal literature where there's some stuff that's pretty close.
Yeah.
But the ability, the interesting thing with animals is that we can use a lot of different tissues. We can use a lot of different cell types. We can use a lot of biologics.
Yeah.
And that can be recombinant proteins. The real challenge for us for our patient population is getting that translated into clinical practice and being able to navigate through those regulatory hurdles.
Yeah.
I did a lot of research with with a recombinant human protein with FGF18, really interesting product. But just to get through into clinical practice takes so many years and such a huge amount of investment. There's been so many studies that have been performed, whether it's cell-based therapies, whether it's recombinant protein, that have got only so far, but then haven't been able to go to the next level because of the lack of funding, the difficulties in being able to do studies that that show a clear clinical benefit. Yeah. So there's it's not like coming up with a new bearing surface.
Yeah.
This is really, really high tech stuff that is ultimately it's going to be challenging.
Is that different in is Canada? So in the US, you've got the FDA who basically set the rules on these things. Does Canada reflect the FDA, or have you your
very similar? We have Health Canada, and Health Canada probably was a little bit more closer aligned to European legislation.
Yeah.
It's now probably now become a little bit more aligned with the FDA.
Okay.
So that's somewhere where we probably do sit in the middle a little bit.
Yeah.
And we do have access to certain therapies that the US wouldn't have. Equally, we don't get some technologies in Canada because there's no adequate remuneration, and that's one of the another challenge that we have. That there's no paying system to be able to pay for these really expensive, something like MACI, for example.
Okay.
So which is the autologous chondrocyte implantation. We can only really do products like that through randomized clinical trials, and FDA regulatory trials.
Even our NICE guidance, for the last 20 years, has been only to use MACI as part of a trial.
Yeah.
The matrix got withdrawn. The fact is, look, the people on ICRS, I know you're involved with them, they are still very big on these cell-based treatments. But I would argue that clinically the evidence is still lacking long-term. And the fact is, I don't feel we've made huge leaps in cartilage restoration over the last 20 years. There's great work going on, but the fact is clinically a plug of bone and cartilage, be it from your own knee, from a non-weight bearing part, or from a donor, is still, I think, the most reliable treatment that we have.
It probably is, but I think you got to give those people a lot of credit as well. They keep working, they keep innovating. They are doing more and more studies, and hopefully, we'll see. It's baby steps, right? And it's not something that you're going to see massive change in a few years. It does take. It's taking decades, but ultimately, if they don't try, we'll never achieve it. Mm-hmm. And I hope at some stage we will get to a point where we have a more reproducible, maybe off-the-shelf option that will be able to give the patients the adequate pain relief and functional improvements that they need.
The work that goes into it is awesome. I've been to a couple of ICRS meetings, International Cartilage Restoration Society. There's strong scientific work being presented. The one thing that people generally at home should know, though, is that essentially it's accepted now that there's no real role for microfracture. Would you agree with that?
Yes, but unfortunately it still has to be utilized as a comparative arm in the majority of studies that we do. So I very rarely do it apart from when I'm involved in an RCT. And microfracture in itself has changed. It's not the old microfracture that we used to do, and things have changed from maybe moving towards nanofracture and various other techniques and drilling rather than use a pick. So the needle just keeps changing, and that can't be such a bad thing.
And you can now also get your AMIC as well.
Yep.
Where you can drill some very small holes. So we used to use these chondral picks. You'd basically compress the bone, you'd destroy everything in a wide area, and you'd just fill the hole that you'd made with all the cartilage would fall in like an avalanche.
Yeah.
Whereas now we're using quite small drills to leave a patent path from the subchondral bone marrow all the way out.
Yeah.
And then you can now put a membrane over the top. Try and
sort of contain it a bit
and give it a scaffold almost, as it were. But the cartilage, I think, is still the thing that we struggle with the most in knee surgery.
Yeah. I think over time we'll probably be focusing, certainly a lot of my research is now sort of focusing more towards what happens at time zero of injury. That's the holy grail, really. Can you actually prevent it from breaking down in the first place?
Right.
That's going to be the game changer, I think, rather than trying to actually repair.
Yeah.
Pete, I'm loving your questions. You can see now how much thought and kind of engagement and discussion goes into what we do, right? In your world, there's no nuance. It's just like there's no discussion of evidence that we do with patients regularly. Yours is bone broke, me fix. Right?
It is.
Yeah.
It really is.
They don't really have a choice.
No, in trauma, you could almost get away with patient consent. I know that's a terrible thing to say, but the choices aren't really there for the majority of trauma operations. Yeah.
Whereas I don't know, but you must be discussing evidence with patients on a regular basis.
Yep.
Yeah, it's something that comes up when we're talking about virtually anything that we do. We'll talk, even when you do lateral tendinosis, which we will come to, you will talk about the evidence, as I do, and say, well, I know that we can reduce your re-injury rate. And I must say, with these elective procedures, the patient doesn't have to have them. There is an alternative.
Exactly.
But they can just modify their activities for a lot of them. And so there's a lot more discussion and nuance into it.
Yeah. Yeah, agreed. Al, can I ask some stupid questions?
Sure, why not?
You've got a young athlete who's, let's say, that they're not elite. They are just an enthused person, like perhaps what you were when you were age 22. And
are you saying I wasn't elite? He heard. Who told you?
And so a keen sports person who does their who ruptures their ACL, isolated injury, and they are coming to you because their knee is unstable, and you are choosing to. You're saying, I'm going to do a ligament reconstruction.
Yep.
They ask you, what's the likelihood? Am I going to need a knee replacement when I'm older? What's your answer to that?
I mean, I always tell them there's that possibility, and we just talked about evidence. We can start throwing numbers at them. 20-year chance of having an osteoarthritis. It's probably going to be around about 50%, depending on on their meniscal if you can preserve their menisci or not.
Yeah.
But just because you get osteoarthritis doesn't mean to say you're going to need a knee replacement.
Yes.
So obviously there's different phenotypes of OA, and so we'd have to see how that progresses. Interestingly, most patients don't care about osteoarthritis, and we did a study not so long ago where we asked our patients what their main goals were following ACL injury and ACL surgery, and we also asked a bunch of surgeons as well. It's kind of interesting because we're completely different, right? Surgeons are all interested in preserving the knee, preserving function, worrying about OA. Patients want to get back to sport. I don't want to have another injury. Very clear, and there's a bit of a Venn diagram. Sorry, there's a bit of overlap, but so you have that conversation, but ultimately they just want to get back to their function.
And then if you take that, go the higher end of the spectrum with the elite athletes, so someone who's playing for Manchester United or playing hockey for one of the top teams, and they same position, they're 25, they ruptured their ACL, and they ask you, what's the likelihood that I will get back to playing at this level?
Yeah, and there's so many nuances to those conversations. At the end of the day, with an elite level athlete, there may be a contract involved. It's their employment. So they want to know how quickly they can get back. Do they have a contract pending? So lots of issues surrounding that. So you have to think that comes into your conversation. Chances of getting back. We always talk about with an elite level athlete, there's very, very high chance of getting back. Actually, when you start looking at the data, it's maybe not as good as we would like to think it is. If you look at patients across the board, it's probably about a 65% return to pre-injury level of sport. Right. Not that great. NFL recently showed that within first 3 years post-injury, there was only, again, 55% of elite level athletes in the NFL were able to get back to their pre-injury level. And that was very dependent on their position as well. So the quarterbacks are getting back, but then a quarterback is getting much more money. They have a different contract, and they have, it's a different skill set. Some of the linebackers, some of the big guys, maybe not as successful, but there may be a little bit more replaceable. So contracts come into the conversation as well. Yeah. So, something we probably don't talk about enough if you look at your sort of non-elite athlete, is should they go back to sport? Always the goal we think about ACL reconstruction is to get them back to their sport. But we know that going back to sport is the biggest risk for them to have another injury, blow out their knee again. And if that happens, their risk of developing OA and needing a knee replacement further is much higher. So maybe we should be actually talking about not going back to at-risk activities. So those are conversations that we have on a daily basis, and it's important as physicians that we do that.
Right. And we're modifying techniques all the time to try and reduce that re-injury rate further. Right. But it's interesting because when we talk to patients about the risk of developing arthritis, and you go, well, there's a 50% chance you'll get it after ACL reconstruction. There are some papers that say your risk is a bit lower, but but like Al said, it doesn't mean because you've got arthritis you need a knee replacement. And there is an argument, well, actually, if you've got your ACL reconstructed and you go back to sport, you're more likely to be more active on your knee than if you do nothing again and you stop doing sport, then actually you're probably not going to injure your knee. Your risk is possibly lower. Yeah. So do you want 20, 30 years of activity and doing whatever you want to do? There's a lot more to it than just bone broke me fix.
Yeah.
No digs.
None whatsoever.
No.
Nothing but respect for my colleague.
Yeah.
Probably you're undermining my
the thinking man's surgery, right? Yeah.
It's only because
the mindset is different between acute and between the acute situation where you've just broken your femur. Usually, patients are not mad keen to hear about the high level evidence around. They do want to know that it's got a high union rate if you put a metal rod down the middle of it, but going into the individual likelihoods of infection and non-union and metalwork failure and requirement for removal of the harbour, etc. I've never found that massively helpful in that acute phase, because actually they just want to know they're going to be all right.
So, but there are areas of controversy such as distal tibial fractures, nail versus.
Absolutely, no, absolutely you do. And also there's discussion around frame versus plate, you have circular frame versus internal fixation. And then once you get into the post-trauma situation where maybe they've gone into non-union, or their alignment's not absolutely perfect, or an operation's been done somewhere else and something's happened that it's not ideal.
Always somewhere else.
Well, it's often in your own department, of course.
No, I'm going to edit that out.
Or indeed in your own.
Always somewhere else. Yeah.
Where actually suddenly the dynamic changes massively, and now you really do have to have very, very clear conversations with the patient in an elective setting. Yeah, really.
I think that one of the bigger challenges that we'll probably face is that patients actually a little bit older, maybe more sedentary, maybe don't need to have an ACL reconstruction. That's where the evidence really starts coming out, because a lot of the time an ACL reconstruction may not be the best thing for them.
Yeah.
And but they often will have a mindset as I got to have it fixed.
Yeah.
And so those are probably a little bit longer conversations, pros and cons of operative versus non-operative treatment.
Yeah. So you must be, as one of the top dogs in knee sports surgery in Canada or in
globally.
Sure, but geographically where you are, people must come to you. You must suck in the big sports players, the movie stars, the kind of the big cheeses from around. How do you deal with your own sort of, I call it imposter syndrome, but do you ever find yourself being wowed by the person in front of you?
Actually, interestingly, I don't see an awful lot of the pro athletes. We don't have a big pro sports team in and around London. And what the majority of pro athletes will do is that they will go to a local guy, right? And we've got great surgeons all across Ontario, all across Canada, and that's the most appropriate thing. So if you're looking after one of the pro teams, they'll either go and see their local guy, or their agent will often send them to one of a handful of people in North America who are dealing the most with the pro athletes. The patients that tend to come and see me is usually, unfortunately for me, is that they've usually failed surgery.
Okay.
So it's, they're looking for a revision, or they're coming to the end of their career and, they want a third opinion, and, let's go and see Getgood, see what he can do. And it's like, a shocker, right? It's like, that's a real home run for me. Thank you very much.
It's not Tom Cruise for a meniscectomy.
No, yeah. So it's, they're challenging, right? So you really are, you're really trying to extend their careers by a year and a half, 2 years. The interesting thing, I think, for me in Canada is that, having not been brought up there, having not been brought up in a world of hockey, of ice hockey, of football, I don't know an awful lot of the players, just to the same extent that maybe some of my colleagues would. Whereas if I was working in the UK or working in Europe, I'd have a much better idea in terms of a lot of the soccer, a lot of the football players coming through, and rugby players. So it's slightly different. So I don't really get that. I'm not that bothered by these guys coming to see me.
Yeah.
And I think that's one benefit of it. But imposter syndrome is an interesting one, because certainly I have for sure faced that throughout the 10 years I've been over there as my career has progressed, because sometimes you can't quite believe what you're doing and why you're doing it, and I have to pinch myself at times that, Are
you talking about being here with us now?
Well, I was just about to say that. I mean, you highlighted some of my career achievements. I can't wait to add this one to the CV. I mean, it'll be in bold capital letters. I could probably retire right now.
I've done it.
Yeah.
Done it.
Pete, have you ever seen Rocky 3?
Yes, I have. Yeah. Which one was that? Was that the one with Dolph Lundgren in it?
No, it's Rocky 4.
Okay.
Rocky 3 is Mr. T, Clubber Lang.
Oh, yeah.
The bad man. He's a physical machine.
Yeah.
So basically, at the beginning of Rocky 3, there's this montage where Rocky's basically having these 10 title defenses in a row, and he's fighting a selection of hand-picked fighters that he can beat.
Right.
And basically, Clubber Lang's like the number one contender, and he can't get a shot at the title.
Right.
So he's in the audience looking at all these, and he's getting really mad because his bums are being knocked out in the first round.
Yeah, yeah.
And he's getting really angry, and he's kind of going around as Rocky's getting more and more famous, and he's like, "Why not me? I should be up there." And That was me around Al for many years.
I was wondering where this was going.
Because
Except the difference being...
well, there's a huge difference. But the thing is, obviously he had the fellowship that I couldn't even get an application form for. Yeah. And then suddenly I'd go to...
And Mr. T ends up winning, doesn't he?
The first fight, but he loses the second fight. Because Rocky regains the eye of the tiger.
That's right, yeah. He got a bit soft, didn't he?
He got soft, yeah.
He got soft.
It was kind of, So, but another time we'll talk about why the Rocky film anthology...
You got soft, but you never really got the eye of the tiger, did you?
So basically, I'd go... No, but so early in your career, I'd go to American Academy. You'd be on stage giving ICL. I'd go to Issaquah. You're on stage. I'd go to Warwick Sports Knee, E4. You're there giving these podiums.
Green with envy.
To a degree, as in, I was trying to work out what has this guy got that he's gone from 0 to 100. He's on stage with Freddie Fu, Andy Williams, these guys, and I couldn't work out. Now I get it, but the thing is, except he's now a guest on my podcast. So
oh dear,
I play the long game. but no, I totally get it why. But do you box?
No, I don't box.
You don't?
No, I never. Do you box?
No.
I thought you said you'd taken a pounding in the ring. But anyway, my point is that you've basically
You've got to cut that out.
No, but you're basically every orthopedic conference going in the world. You're there. You're on stage. You've got this huge presence for what we call soft tissue knee now, right? We all know it's much more complicated. It's cartilage, it's meniscus, it's
very, very complicated.
Very complicated.
There's so much more to it. But you sit on a lot of boards, program chairs. What you do is insane. How did that come about? How did it start? When did you first get the big invites? What did you do to?
Good question. I mean, I guess opportunities, and I think one of my strengths is probably networking. I'm pretty good at meeting people, and I think probably the ICRS was huge. The International Cartilage Repair Society, that sort of gave me, that was my opportunity when I first started. Got to meet a bunch of different people. Basque Traveling Fellowship, so that was in 2009, I think it was, and I visited the States and spent a bit of time with a few guys there, and it's actually quite a funny story. Actually, I went to an ICRS surgical skills meeting, and that was the start of the Traveling Fellowship. And Brian Cole was there, Bill Bugby, Jack Farr. These are guys who didn't know at the time, but legends in the field. And it was Halloween, and we went out. We had a night out, and I managed to blag myself and Bill and a couple of other guys into the Versace mansion on Halloween night. It was a good party. And so that was the chat the next day at the course, was that we managed to get into the Versace mansion. And then I went and did these different tours. So, went into Jack Farr's OR, and the nursing staff were like, "Oh, you're the guy that got into the Versace mansion." And it just carried on right the way around the tour. And it sounds like that's a bit of a silly thing, but it was just it was an opening talking point. And I got to meet these people and got on very well with them. And, thankfully with the research I'd done in Cambridge, I had a bit of substance to go with, having a bit of a laugh. And I got to know them. And, they've been friends and mentors ever since. And, those are the guys that started opening doors for me. And then when I got those opportunities, I took the opportunities. And, I think the easiest thing, it's difficult to be on a podium and talking about other people's research. It's much, much easier if you have your own research to talk about. Yeah. And at an early stage of your career, I recognized very early that I couldn't talk about clinical practice. I don't have the experience. How can I go out and talk about my last 10 years of ACL reconstruction? I just don't have that data. Plus, I didn't want to talk about other people's work. So, we did some biomechanics studies. I could talk about animal studies. Those are things that you can do in a very quick turnaround. And that had then substance to it, and it got me an opportunity to talk on stage. And then once you get those opportunities, then things start to snowball. And I've been very fortunate. I
mean, I think you're being modest in terms of your networking. You've clearly, that's a strength of yours, but you've taken the impetus with your research, and the research is really accelerated. It's all clinically relevant. It's huge stuff, and it's developed in its complexity and significance. And so, was that an active decision of yours?
Yes. I mean, I knew I wanted to do some research, and when I was a resident or registrar, I was really not I wasn't very good at research, but mainly because I wasn't really interested in doing research for research's sake, right? I wanted, as soon as I got an opportunity to do some research into knees that were clinically translatable things that actually would be interesting for me.
Answering a clinical
ask a
question that you
right?
had. Yeah.
It's like, wow, talk about a light bulb moment. And that was just huge. And so it really did snowball after that. And again, the whole anterolateral ligament lateral tenodesis thing, that was very topical when I first started in Canada. So we started researching that, anatomy studies, biomechanics studies, got into clinical studies, great group of people around us. And, so therefore those were really important clinical questions that we were able to answer. So it was actually relatively straightforward. But
could you just explain to my ignorant friend what a lateral tenodesis is, what the stability trial was, and why it's so impactful?
Wow, have you got half an hour?
You've got to keep this as simple languages, like monosyllabic.
I guess the most simple thing, we talked about it already, our young patients are high risk of re-injury. This is the conversation I have on a daily basis. My risk of re-injury in my mid-40s, I've had an ACL reconstruction, 3 to 5% by 2 years.
Yeah.
Take someone who's under the age of 20, 15 to 20%, maybe even higher.
Right.
So big difference. Throughout my fellowships, I worked with a lot of really great surgeons, and I saw a lot of variability in outcome. And I was like, wow, this is pretty disappointing. As a surgeon, you want to have, you want to try and make your confidence interval as narrow as possible. And there's this huge variability. So what can we do surgically? And recognizing there's lots of other things going on from a rehabilitation point of view as well. But anyway, so I got interested in the anterolateral side of the knee. And so by 2012, there's a Belgian study that developed that earmarked the anterolateral ligament. Been around for years, decades. A number of people have talked about it. Kaplan talked about it. Glenn Terry talked about it. And it was just essentially a structure in the lateral side of the knee to reduce your risk of having a pivot shift. And so we did some studies in that area, did a clinical study looking at the addition of a lateral tenodesis. And a lateral tenodesis is really just a check rein on the lateral side of the knee to prevent anterolateral translation, which is essentially your pivot shift. And we did a large randomized clinical trial. So this was a multi-center study sponsored by Isocos at the time. And, it's kind of interesting. We say only, it was a huge amount of money for their point of view, but it was about $200,000 for a 9-center randomized trial.
Wow.
We recruited 600 patients.
Wow, that's cheap.
So
that's nothing. Pete had $3 million for your trial, didn't you?
It was, I want to frame this the right way. It was a huge amount of money from Isocos' point of view. The thing that was special about it was that the sites that were involved in the study, they essentially did it. It was like charitable what they did.
Yeah.
They had infrastructure already. We all got together. I was in my first 2 years of practice, and I had all these giants of orthopedics in Canada that got behind me and helped me out with this study. And we knocked off everyone said we would never recruit 600 plus patients for a randomized clinical trial in ACL reconstruction. It had never been done, but we achieved those numbers, and we showed with the lateral tenodesis that we could reduce failure rates by over 50%. So it was a big impact at the time, and continues to be a big impact, I think. It's been...
And that is now your standard practices in young people who have a 20% failure rate, or are definitely going back to sport, to pivoting sport.
Yes and no. Yes and no, in that was the surgery that we did was a hamstring tendon autograft ACL reconstruction. I've pivoted away from that, excuse the pun, and moved to using either a patella tendon or a quadricep tendon. And so probably some patients don't necessarily need to have a lateral tenodesis with those graft types. Right. But that's our second trial. We're now doing Stability 2, which that's a Canadian Institute of Health Research and an NIH funded study with our colleagues at the University of Pittsburgh. And that's 28 sites, 1,200 patients.
And so you're comparing what?
BTB and quad with or without tenodesis. Right. So it's now taking it to the next level, doubling the number of patients. And that's going to be a huge study if we ever manage to get it completed. It's just it's a bit of a monster.
So I can comment on the stability trial, because that's a hamstring ACL. So the re-rupture in that went from 11% down to 4% by adding a lateral tenodesis.
Yeah.
And predominantly in the UK, we're still hamstring, graft, ACLs. US latest evidence would suggest 50-50.
Yeah, it's
hamstring, BTB, or
but
other.
It depends on the patient population. Certainly the young athletes, most will be getting a BTB.
Yeah. But the thing that's revolutionized my practice, certainly over the last 3 or 4 years, and to be fair, Andy Williams has done a lot of work over here, and Andy and Alex Dodds did it. So basically, these Belgian guys described this anterolateral ligament, and it went viral. It was on CNN, Fox News, in the Times newspaper. These guys were giving interviews all over the world about a ligament that's been discovered 100 years later.
And there was a lot of mockery at the same time, wasn't there? From the non-knee surgeons, a lot
From the
of
non-knee surgeons.
The knee guys have found another
Yeah.
ligament to replace,
Yeah.
haven't they?
but the irony is that Andy Williams and Alex Dodds were doing that work with Andrew Amos at the exact same time and got beaten to publication like by a day.
Right.
But they've done a lot of work, and so I use Andy's technique that he wrote out, the modified Lemaire. And so for the last 3 or 4 years, I do lateral tendesis for every single revision ACL.
Yeah.
I will do it for any elite athlete. I'll do it for anyone who's hypermobile. I will do it for anyone who's got significant pre-surgical laxity.
Yeah.
And so that's a procedure that's gone from 0 to 100 in as much that, and I would say 99% of knee surgeons will use a lateral tendesis at some point in their practice.
Yeah, it's kind of insane. I mean, when I first started talking about it at the academy, and maybe 6 years or so ago, before we had the results of the study, I was practically felt like I was getting booed off the podium. It was like, what are you talking about?
That was me booing you. That's like Mr. T.
Who's that joker? What does he know? But it was crazy, and now it's actually it's really cool. I can sit back and watch other people talking about it, and so it's been huge, and it's been an enjoyable journey for sure.
Yeah.
Can't let you go without asking about the quads tendon. So Pete, we've essentially used the hamstring ACL or a patellar tendon as being the graft for an ACL reconstruction since last 20 years, right?
Yeah.
And now increasingly you hear about the quads tendon. And whenever there's a meeting or a panel discussion, and there'll be like 5 people on the panel, and there'll be a complex case come up. They go, "What graft are you using?" And we go, quad. And you're kind of like, this thing's gone from 0 to 1,000.
Yeah.
So because now you can basically take the quadriceps tendon and use that instead.
Yeah.
And that's kind of come out of nowhere over the last, well, not over and over, but over the last few years, it's increased massively in popularity.
Yep.
So how's your practice changed in that time?
I mean, the study is pushing an awful lot of that. I do an awful lot more quads just because of the study. I mean, I was using quads for PCLs a lot. I was using quads for patients who were, mixed martial arts or wrestlers, or anybody who had a...
What's the advantage of a quad? Is it that much stronger?
Well, no, I guess the perceived potential benefit would be that you don't get as much anterior knee pain. That's probably
as a patellar tendon.
Yeah,
Okay.
So as a comparator to patellar tendon. But other than that, the data isn't there. There's some studies that are showing equivalence with a hamstring tendon. I would argue that equivalence with a hamstring tendon is not a great comparator.
Yeah.
So I think the quad, we don't know enough about it, and hence stability too. We will know something about it soon enough. But there's no question there's a big industry push. One of the major advantages of a quad tendon for industry was that they could develop instrumentation for quad harvest. They could look at new fixation devices. So it really transformed the industry side of things. And that's, over and above, if you compare it to lateral tenodesis, I use a staple, you probably use a suture anchor or something.
Exactly.
So it's massive difference from that point of view. So, if you're a quad surgeon, you're an industry dream. If you're a lateral tenodesis, not so much.
Yeah.
We do often find ourselves being swept along by industry, don't we? As orthopedics in general, because industry is so knitted into so many of the operations we do. We often find ourselves being driven by them rather than by evidence or by our own ideas.
Yeah, no, 100%. And it's a symbiotic relationship. I mean, you can't get away from it, and nor should we try and get away from it. You want to actually. I think that was one of the real strengths of this society. For example, ICRS, is that very early they brought industry in, and industry were part of the meeting. They were part of the board, and so we were doing things together because ultimately you're trying to develop technologies that would improve our patient outcomes. Yeah. They're an integral part of that development process.
Agreed.
So you have to be on board with that. Equally, you got as a physician, you got to understand the potential downsides of that, and you got to be able to start looking at the evidence behind things.
So I want to push you a little bit more on the quad, because the hamstring and the patellar tendon have been the gold standard since ACL reconstruction began. The challenge I have with the quad is the evidence is still not out there. So given that your practice is so evidence-based, I'm just trying to understand what's made you conceptually come to terms with using the quad tendon.
Well, as I said, it's for very specific patient population, and I'm pretty happy that the evidence is equivalent to a hamstring, and so if I the question for me is really, is it better, or does it provide equivalent outcomes or better than a patella tendon? So patella tendon would still be my graft of choice for an elite level athlete. But if there's a reason why I wouldn't want to use a patella tendon, maybe patella length, kneeling sports, such as wrestling, mixed martial arts, then I would use a quadricep tendon.
Yeah.
But, again, have that conversation. And the conversation at the moment with Stability 2 patients is really interesting because so many of them want to have a tenodesis. And, we have to say, well, there's potential negatives with that. This concept of being randomized to either a patella tendon or a quadricep tendon, the evidence does not point one or other is superior. So we have complete equipoise in being able to have that conversation. So, it's a really interesting, it's an interesting study because I have to be very confident to say I don't know the answer.
Yeah.
And I guess maybe not everybody is comfortable with that sort of concept. I think as knee surgeons, though, you have to be in a position where you should be able to offer different grafts, and I think ACL reconstruction, whether it's tenodesis or whatever we're doing, is moving towards a sort of risk assessment, a la carte surgery for, patient specific surgery. I don't think it's not cookie cutter anymore. It's not one size fits all. Coming out with all the cliches here, aren't I?
Yeah.
And so we have
Game of two halves.
We have to be able to do what's the best option for our patient, and eventually we hope we'll have that data to be able to support those decisions.
But based on what you're saying, then it sounds as though the quad tendon is one that you're using more so for revision ACLs than primaries. Yeah,
maybe at the moment. Yeah, it's probably 50-50. Again, it's difficult to know because the study is really skewing my practice. As much as my sort of at risk athlete, those are the patients that I'm trying to get in the study, in which case then it really just skews the different the grafts that I use.
I mean, this study is going to be the one that gives us the evidence. This is the study we've been waiting for, which is quad tendon versus patella tendon plus minus tenodesis. Any early indications?
Nope.
Nothing.
You don't get early.
No. Full equipoise until the results are in. Just wink if it's patella tendon.
Saying nothing.
Tell us about life in Canada. How did your wife make the transition? How did she find it? Sorry, how did she how was the sort of taking your family to Canada?
Yeah, I would say I would say it's pretty seamless. If she was sitting here, she may say differently. No, I think we settled in very, very easily. Both of our kids were one was born. So my eldest Jasper was born in Canada when we were there in fellowship, and then my youngest Freddie was born in the UK. So. When we moved back there, they were both under the age of 2. So very straightforward. It's kind of interesting because Jasper had an English accent when he moved there, and now they've got full-on Canadian accents, which is kind of cool. But yeah,
can he switch? Can he turn it on though?
Oh, totally. They're here with me this week, and I arrived late. I got in yesterday. They've been here for the weekend, and as soon as I arrived at the hotel, they were both speaking in English accents. It was pretty awesome. So they're all over the place, and then they can do the Northern Irish accent as well. So they're all over it. They're pretty cool kids. But I think the transition was pretty easy for us, and it took a while. Like any big move, getting set in society, built, getting your friend base, and now we're very well set up there, and life is good. Yeah. But you got to enjoy. We enjoy the outdoors. We run a lot. We bike a lot, and the kids enjoy the sports. We enjoy skiing. We enjoy being outdoors. So it makes it a lot easier.
Yeah.
Are you a big ice hockey fan now?
No. Sorry.
It's a hard game.
Sorry, Canada.
Canada's national sport. I just can't follow the puck.
Yeah, it's quite hard to
when they're hitting it. I don't know where it is, and until the buzzer goes. All right, it's a goal.
Well, it's one of those sports, and I'm sure most Canadians say the same about even some rugby. Not unless you play the sport. Cricket's probably the same. Yes. Not unless you play the sport and really understand those little nuances which we really enjoy.
Yeah. It's
the same for hockey for them. I'm clueless to a lot of what's going on.
Yeah.
And the line changes. There's just so much going on, but it's like they totally know what to watch and when to watch. So
which you don't know.
No.
Talking of cricket, Pete's only a fan of naked cricket, but that's a story for another day. Can I ask you about running? Because one thing, Pete, I don't think you picked up on this. He's a huge runner.
Yeah.
A whole bunch of ultra marathons.
So when you say a huge runner, are you talking about my size again, or what?
So running is your passion for you.
Yeah.
And you've done a few ultra marathons.
Correct.
Pete, do you know the Marathon des Sables?
No.
It's the marathon in the sands. It's 6 marathons in 6 days in the middle of the Sahara Desert.
Right.
And Al did that.
Wow. How was it?
It was pretty hot. Yeah, it was fun. That was 2012.
Yeah, it's called the toughest foot race in the world. So running's a big thing of yours. I see you on Twitter posting pictures of you running quite a bit.
Yeah, it's probably about the only personal stuff I ever tweet. Yeah, I mean, I enjoy it. I mean, I travel a lot, as you know, and one of the things I like to do is bring my trainers, and anywhere I go, I put my trainers on, go for a run, see the sights on the road, and then get on with the meeting. So I find that a great way of being able to introduce a city to me. And yeah, I've loved running. I started running probably around about 25, 26 years old after I stopped playing rugby. I had a few years of not doing very much, put on a bit of weight, and thought, okay, I better
It's got to stop. Yeah.
And yeah, got into running. My wife and I run together. And
the dog.
And the dog. And yeah, we started doing some mountain marathons and so Swiss Alpine marathons. They're fun. And then slowly started to get into ultra marathons. I haven't done one of those in a while though.
Right.
Yeah. So, but the Marathon des Sables was a blast. But it's actually funny story. But this is my claim to fame with this one, is that one of my tent mates, this guy called Bill Coles, and he was an ex columnist for the Sun, and so he was there on the race, basically doing taking notes because he wanted to write a novel. And he'd written a couple of other novels before about his time at Eton, whatever. He's quite an interesting guy.
Yeah.
Anyway, so he ended up after the race writing a romantic novel set in Morocco during the Marathon des Sables, and we were all characters in it. So,
right.
Right, so I am a character in this book.
Yeah.
I was Carlo.
Right.
Carlo. I think I was described as a bit of a rascal. So some great stories from that, and yeah, we had some pretty interesting stuff go into there.
So you run, you stop, you sleep in your tent.
Yeah.
And
So
then you run, you sleep in your tent.
So you have like a backpack. You got to carry all your own food, your rationed water. So everyone gets the same amount of water. So I had the same amount of water as the little Moroccan guy who ended up winning the race. And so for me, you know, whilst I was probably the fittest I've ever been in my life, and I was running an awful lot before that, leading up to that time, put me in the desert and try and run, it was a bit of a nightmare. So I think I ran for the first 2 days, and then after that it was a lot of speed walking and just trying to manage really physiology. You know, it's just trying not to get too dehydrated. You know, if you ended up on an IV, you lost an hour of your time. So and it was really just it was a matter of looking after your body. I mean, I saw a lot of people who were in absolute pieces and really suffered and probably didn't enjoy the week, whereas I kind of just went through the, you know, and really just thought about what I was doing, and I had a lot of fun, met some really cool people, came somewhere in the middle of the pack, was never going to win the damn thing. So and there were days where it was just really probably the worst experience of my life. I remember there's one stage, the fourth day is a double marathon, so it's 81 kilometers that we had to cross these sand dunes, and sand dunes, it was in the middle of the night, and they had this huge big laser light going up in the air, in the sky, and that was your way marker. So you were just following this laser light, thinking it was just across the next hill, just over the next hill. I think it was about 8 hours of just heading towards this green laser light. It was just soul destroying. And then, you know, the last few hours, I think that stage took me about 22 hours or something. It was just insane. And all I wanted to do was get back to the tent. I had to get back, and I had these pepperammis, and that was, you know, get back to the tent, I could have my pepperami, and I was dying, and I just wanted to get back. And by the time I got back to the tent, there was a sandstorm blowing. I was sitting in the middle of the tent, and every time I took a breath in, I had a mouthful of sand. I just sat in the middle of the tent, pretty much in tears, just totally broken, absolute all-time low. And then the sun came up, and we had a day off. You know, those little cans of Coke you used to get on flights. We each got a can of Coke, and that was the sort of, well done, you finished the long stage. And once you finish the long stage, you've pretty much, it's done. You know, the race is done. You've still got another 2 or 3 marathons to do, but that's child's play. And you know, so I was sitting in the sun, drying off, having my Coke, and just thinking, wow, this is the best. This is the life. I'd eaten my pepperami. So, you know, you go from the absolute lowest to a high, and I think that's some of the things that you get from pushing yourself a little bit. You know, I do feel suffering is good from time to time. You know, we all live incredibly privileged lives, and it was a privilege to be there and do it. It's not a cheap thing to do, but at the same time, just to suffer a little bit is never a bad thing. You learn an awful lot about yourself.
It's true.
You literally, I mean, you push yourself to the absolute limit as humanly possible, probably doing that, right?
Well, it certainly was humanly possibly for me anyway. I'm sure there's a lot of other people who could push themselves a little bit further.
Pete, do you think we should sign up for that?
You guys would have a laugh. You could you could do a podcast. You could do Ortho Hub in the desert.
Yeah, we can.
Yeah, we'd be dead.
It'd be outstanding. You'd carry all your own gear.
Yeah. The funny thing is, we'll have Fabio Marco carrying the gear for us and our rations and wheeling us along. No, so I treat a lot of ultra distance runners by chance. I think I treated a few. I don't quite know. I think it on some running forum somewhere. Someone gave my name, and so I treat a lot of people who do Marathon des Sables. There's another one. I forgot the name. Marathon du Médoc, which is basically a marathon in France, but you drink cheese and wine as you go around.
Oh yeah. That's in Bordeaux. Yeah.
There's one that goes around Iceland as well, isn't there?
Yeah, there's another one where it's basically the 5 days of the Tour de France.
Yep.
You're in I don't know if it's the Pyrenees or the Alps or the Himalayas. I don't really know. But
Himalayas.
Okay, maybe not the Himalayas.
I would hedge a guess that it's probably not there. Maybe it goes on tour once in a while. Who knows?
But basically, you're up and down the mountains, but it's a 5-day foot race on the thing. You see people on the bikes, but they're not on the foot. Yeah. But sleep counts as part of your time. So if you sleep, you lose out on time.
Clock's still ticking.
And people come in absolutely trashed. And the number of people I see who go, my knee hurts. I go, okay, when does it hurt? I go, whenever I'm running, about mile 52, my knee hurts. Where does it hurt? They go right there and point to their kneecap. And I just sigh. And it's kind of like, but the problem is you can't just say, well, why don't you stop running at mile 51? Yeah. Because if you tell a runner not to run, you might as well shit in their bed, But they're challenging people to treat, aren't they?
For 100%. And, they want to keep going. And, you just got to recognize that. As you said, they're not going to stop. So it's just a matter of trying to help them out. And, sometimes you just need to get them to just, reduce their training volume and then get back at it. And the interesting thing is so much is rehabilitation related.
Totally.
And they don't get that because they think, well, I'm a runner. And this is always for me. It's always do as I say, not as I do. Because I have all sorts of problems with my knees, but I never do the rehab as I probably should do. And but you have to sort of take them back a stage and say, okay, now you need to do this because you're having a problem. And as long as you get them to buy into that, then it can often work.
They never want to see a physio and they never want to do basic rehab. And yet they're like, well, I've run 50 marathons. I don't need someone to tell me how to do some squats. And yet 99% of the time, that's the cure.
Yep.
Yeah. Tell us about Putang.
Poontang?
Putang? Is it Putang? Is it Putane? Or
Poutine. I was like, wow. I don't know if you saw my face there. I was like, wow.
Poontang is something that we can't talk about here.
Okay,
we can get cancelled for that. Poutine is a delicacy.
Wow. I was like, I've been on an Asia traveling fellowship. I was like, what? That was wild.
I'm sweating.
I'm starting to sweat. Poutine.
Yeah.
Poutine. Oh, gravy. So
tell us about poutine.
So fries or chips, fries, gravy, and cheese curds.
Cheese curds.
Cheese curds. It's a very.
Nice.
You know what? It's variable depending where you get it from. It's a big Quebec thing, and but the best we've ever had. The best I've ever had was in Big White in British Columbia ski resort. Fabulous. Throw some bacon in there, some onions and peas. Amazing.
A lot of gravy on them as well.
Oh yeah. My kids love it. They love poutine.
Right.
That's the thing. The
okay,
kids.
so
the kids.
If you're brought up with it as a kid,
the kids just want to. They ski and then they want to have poutine.
Yeah.
Play hockey. Poutine.
Aren't there fast food restaurants that just serve poutine over there?
Probably.
I'm
not a massive connoisseur of poutine. You're probably asking the wrong guy.
I mainly, when I'm in Canada, I mainly spend my time in food courts. I think I've seen it quite a bit. Pete, just learn how to pronounce it.
Okay, all right.
Can I ask you, we're going to, just to kind of, as we draw things to a close, who has mentored you and who are your mentors and key influences? You don't have to name us, anyone else.
So apart from you, Kash,
sitting down there in the audience, that little speck distance.
I don't know if you ever noticed any time you were down there, I always give you a little dot, little wink. Yeah, just a little. Good to see you there, buddy. Makes all the difference that you're there supporting me. No, I have so many, and I always find the conversation about mentorship always interesting, right? Because I think I have many mentors in different parts of my life, and different parts of my both professional and private life, and my personal life, and I think and I think that's really important. You know, I would say that, you know, one person, well, I can name a few, would be a guy, Tony Buller. Tony was a surgeon in Peterborough, and he was my second year of my residency training in Cambridge, registrar training. I always get, you know, there's the Canadian coming out.
We're international audiences, all right.
That's all right. And so Tony was the guy. He was a knee surgeon, and he really introduced me to cartilage repair as well, actually, and was very, very tough taskmaster in terms of surgical technique. He's one of those guys that when you ever work with was always saying, you know, that's not good enough, this should be better, and just driving you to be always reaching that level of excellence that he expected. And subsequently became great friends, you know, to the point now like he's like a granddad to my kids. I mean, just an incredible person. You know, other people, I'm going to miss some out. I mean, Bob Litchfield, who's my partner in London, huge influence.
Ontario.
One of the London, Ontario, yes. And one of the main reasons I went back there. Mark Hurd, just can't speak highly enough of that guy. I mean, again, the experience in the OR, what he taught me in the OR, but also just outside of the OR and trying to get that work-life balance thing going. Yeah. Tim Spalding continues to be huge in terms of, you know, the influence he's had on me, and, you know, and we still did a lot of work together. And then there are just, you know, so many others that I've had the opportunity to work with, you know, likes of Brian Cole, Jack Farr. Those are guys that have just, you know, as I said before, really opened up many doors and have remained great friends ever since. So yeah, I'm probably missing out a ton, and anybody have missed any names there, I apologize, but yeah, just, you know, I've been very, very fortunate to have a lot of really great people that have had an influence on my career. So yeah, lucky. Yeah.
No, that's awesome. We should get Brian Cole on, actually. You would love Brian Cole.
Oh, he's special. Oh, he's another one. Yeah, no.
Yeah,
but he does a bit of shoulder. It's a shoulder as well.
Yeah,
so,
yeah. We can spread it out. No, he is a fascinating man, and he's just a million miles an hour. He's the most manic person I think I've probably ever met.
Yeah. Yeah, I mean, I think certainly what I would say probably in his earlier career he was probably, you know, to a degree, and there's no question that I wouldn't say he's slowing down, but he's definitely much more chilled and just so much more thoughtful about what he does and the influence. And, you know, he's had a huge influence on what I do and why I do it. And then, you know, we climbed a mountain together a few years ago, Mount Baker in Washington State. So again, that whole concept of doing things outside of work, and, you know, that, and really trying to focus on, you know, keeping, you know, healthy and you know, keeping active and doing things with a bunch of friends is huge.
Al, what are your plans for the future?
Well, you know, I think the big thing at the moment is really just focusing on getting Stability 2 finished. That's, you know, I can't see much past that at the moment, you know, that's, and then post that study, I mean, is doing the things that I enjoy doing, you know, coming up with the next research question that we want to ask, keeping involved with societies. You know, I'm really enjoying my time at the moment in the Middle East. That's been really fascinating, getting out there and working out there. You know, go out there about 4 times a year.
And, what do you do out there?
So I work in 2 different centres, so both in Doha and in Abu Dhabi. So again, just doing complex knee surgery, and you know, that offers a different type of patient. You know, really complex surgery that, you know, very, very, very challenging patients. It takes the skill level to, you know, it's another challenge, yeah. And that's been really fascinating. So I'll continue to do that, and then also focus on the family. You know, I think probably I keep saying I'm lucky. I am very lucky, but I'm also, you know, I'm fortunate that I can maybe pick and choose a little bit more, and I don't feel that I have to do every single meeting. Yeah. And so, you know, the future brings hopefully being a bit more selective. So I can try and get maybe a slightly better balance in work and life. I always find that conversation a little bit challenging because it's very difficult to get true equilibrium, right? Yeah. But you know, spending more time with the family is a huge part, and I think that's what COVID also really highlighted. That
it told us, didn't it?
Totally, and I really enjoyed that, having that time at home and really you know, engaging with the kids was just fantastic, and still, you know, and really just want to continue doing that.
Yeah. A lot of our guests who've come on this podcast have talked about reinventing themselves when you get into your like late 40s, 50s, into the back end of your career, reinventing yourself into something totally different, like a big editor of a journal, or a politician, or someone who's driving change, writing new guidelines. Have you got any ambitions for that kind of thing?
No, I still think I'm pretty early in my career. I mean, I guess I'm now officially mid-career, and I want to carry on doing the things that I'm doing. I still love clinical work. I still like answering or trying to answer big research questions.
Yeah.
At some point in time, like everything gets a little bit monotonous at some point in time, and so you do maybe need to reinvent yourself. I don't feel I've reached that yet. I think I've still got a long way to go before that. I don't necessarily have great aspirations to be an administrator, for example. I think one of the things certainly in North America is eventually you come to leadership roles. That's always going to be the ultimate transition, and scaling back a little bit on your clinical work, taking on more administrative responsibility, and ultimately going for a chair of a department or something. That's never been my real goal. I still see myself as a clinician. I think whilst I do get to do a lot of research, I still think that my strongest asset is the surgery, and I really enjoy the surgery, and I continue. I enjoy training our fellows and our residents, although I still find that probably the most stressful part of my job. But I don't feel at any stage that I need to change that at the moment.
Fantastic. Al, thank you very much for coming.
Thanks
flying
very
all the
much.
way over here. And it's been fascinating. It's been great to talk to you finally. It's been well worth the wait. I'm off to trademark Stability 3.
Sorry, mate. It's already trademarked. Late again, Cash. Late again.
All right. Let's get Fabio. Can we go buy him some pepperami? Thank you. Awesome. Thanks for that. Pete, who's our next guest?
Oh, next guest is Chip Rout. Chip Rout is
Chip Rout.
The Chip Rout. He's a pelvic and acetabular surgeon, works in Houston in Texas. He is, I'd say at the outset, he's probably, within my specialty, he's one of the most impressive people. I've met him quite a few times. He's one of the most impressive people I think I've ever met. And I don't say that lightly. He's a little bit Marmite, he's a proper old school hard ass. He's totally uncompromising. He loves his guns. He loves hunting. He loves, he's an amazing trainer, and he's proper old school Texan. Always carries a weapon with him wherever he goes. He's the real deal. Okay. But above all, he is someone who is doing a very challenging breed of surgery, fixing pelvic fractures, and he is unbelievably good at it.
And is it fair to say he intimidates you a little?
He totally does. I think he intimidates most people in most rooms. He carries that kind of, that sort of, persona of someone who is very difficult to fuck with in a group situation.
And having a gun helps.
Yeah, well, actually, I've never seen him wield a weapon. I've never seen that happen. But he carries a presence that is unmatched.
Fantastic. Well, I'm really looking forward to watching you squirm. With that, thank you very much, everyone. Goodbye.
Thanks very much, guys.
Thanks, guys.
See you next time.
Appreciate it.